So hemolytic anemia. So the first concept is basically there is hemolysis happening. Okay. So when hemolysis is happening, automatically as a compensation, there is increased erythropoiesis. So the RBC production is going to be high. So where is it going to happen? It's going to be in the bone marrow. So automatically the medullary spaces is going to expand, and you have all those skeletal deformities, especially in thalassemia. You look into the maxillary prominence, frontal bossing, and all those is because of the increased erythropoiesis, because of the expansion of medullary spaces. Also, you have extramedullary erythropoiesis other than the bone marrow. So where are those places? Your liver, spleen. Spleen is the major place of extramedullary erythropoiesis. So why you get splenomegaly in a case of thalassemia? It is because of the extramedullary erythropoiesis. And whenever there is increased erythropoiesis, the RBC turnover is more. So the precursors will be more. So one important precursor is your reticulocyte. So whenever there is any hemolysis, reticulocytes will be elevated. There is one exception which I will discuss as you go on. So this is hemolysis. So increased erythropoiesis, increased reticulocytes. And whenever the RBCs are going to lyse, the LDH which is in the RBC is going to release. So you have increased LDH. The hemoglobin will be binding to the haptoglobin. So haptoglobin will get reduced, hemopexin will be reduced. So whenever hemolysis, LDH is elevated, which is released from the RBC, haptoglobin is reduced, hemopexin is reduced. And if it is intravascular hemolysis predominating, mind you, any hemolysis you have all these, but in intravascular predominating, the hemoglobin, the lysed hemoglobin, after binding to the haptoglobin, the excess hemoglobin is going to get excreted as hemoglobinuria and hemosiderunuria. So important signs of hemolysis is increased LDH, the haptoglobin is going to get reduced, hemopexin is going to reduce, hemoglobinuria is going to be there, especially intravascular hemolysis, hemosiderunuria is going to be there. Then if it is going to be extravascular hemolysis, spleen is going to be the main site of extravascular hemolysis. So you are going to have splenomegaly, and since the hemolysis is in the spleen, it's going to get converted into bilirubin and jaundice. So extravascular hemolysis, if it is predominating, you will have splenomegaly, you will have jaundice, and you have bilirubin. Intravascular, you don't have much time for the jaundice and bilirubin. It straightly enters into the urine as hemoglobinuria. But mind you, any hemolysis, it's going to be, all features is going to be there, which means both intravascular and extravascular is going to be there in any hemolysis. It's just which is predominating in which part. Okay. So some conditions, intravascular hemolysis is going to predominate, and in some extravascular is going to predominate. So obviously the lifespan is going to get reduced. So you have questions on that. So the normal RBC span is 110 to 120 days. Some question has been asked in that. For neonate, it's going to be 90 days. And for preterm, it's going to be even less. It's going to be less than 60 days. Okay. So we will move on to the next concept. So it's the concept 2. Types of cells and the types of diseases. Very often you might be asked questions related to that. So spherocytes, so very easy to answer, hereditary spherocytosis, but it's not just hereditary spherocytosis. You have autoimmune hemolytic anemia. In autoimmune hemolytic anemia also you get spherocytes. How to differentiate? Simple, you do the Coombs test. Coombs test is positive in autoimmune hemolytic anemia. Coombs test is negative in hereditary spherocytosis. So in a newborn, child is presenting with hemolysis, you are seeing spherocytes, you do the Coombs test. Coombs test is positive, probably it is Rh negative incompatibility, hemolytic disease. It could be autoimmune or where Rh is an isoimmune. So the Coombs test will help you in determining whether it is due to immune-mediated hemolytic anemia or spherocytosis, hereditary spherocytosis. Okay, spherocytes. Then you have bite cells and Heinz bodies. Okay, So which is seen in G6pd deficiency. So G6pd deficiency, the hemoglobin is getting denatured, forming Heinz bodies. These Heinz bodies are eaten up by the macrophages in the spleen. So you will have bite cells. So the RBCs will have bite cells. So bite cells will be there. Then target cells, remember target cells are feature of hemoglobinopathies. Which are the hemoglobinopathies? So thalassemia, sickle cell disease, you have target cells. So remember T for thalassemia. So target cells, hemoglobinopathies. Schistocytes is nothing but broken RBCs, helmet cells. So when it's due to mechanical trauma. So mechanical trauma, whenever there is a prosthetic wall, mechanical trauma, schistocytes. Similarly, if there is a platelet plug everywhere in the blood vessels, so the RBCs are going to traverse through that. So it will result in microangiopathic hemolytic anemia due to small platelet plugs. So you will have microangiopathic hemolytic anemia. So telltale sign will be schistocytes. Schistocytes are nothing but fragmented RBCs, helmet cells and fragmented RBCs. And basophilic stippling, so remember lead toxicity. Basophilic stippling, lead toxicity. Okay, so this is the concept 2. So sometimes you will get any MCQ about the types of cells. Okay, then comes the concept 3. Okay, immune hemolytic anemias. So immune hemolytic anemias, the telltale sign will be Coombs test is going to be positive. Okay, Coombs test is going to be positive. Most important significant hemolytic disease is hemolytic disease of the newborn. In newborns, the RH incompatibility is the most important hemolytic anemia in pediatrics itself. In pediatrics, any hemolytic disease which is so common, if you say it is hemolytic disease of the newborn, which is due to RH incompatibility, OA incompatibility, etc. It is called isoimmune or alloimmune because the antibodies are acting against some other member of the same species. Okay, autoimmune is against the same person. So here it is isoimmune because the mother's antibodies are going to act on the babies. Okay, and coming to autoimmune hemolytic anemia, any hemolytic anemia, this is for classification, you will not get questions out of it. So it could be primary or idiopathic where you don't have any reason, or it could be secondary. The secondary is an infection can trigger, drugs can trigger, or immunologic diseases like SLE can trigger the autoimmune hemolytic anemia, or sometimes immunodeficiency diseases can trigger the autoimmune hemolytic anemia. Okay. Okay, so now comes the concept 4. In autoimmune hemolytic anemia, we are dividing them into warm autoimmune hemolytic anemia, cold autohemolytic anemia, cold antibodies, due to cold antibodies, and warm antibodies. So simple 4-5 points. Warm antibodies are because of IgG. So remember G for garam. Okay, warm. So IgG mediated. So warm antibodies are because of IgG. Cold antibodies is because of IgM. So as you know, warm means the antibodies are active at almost the body temperature. So 35 to 40 degrees Celsius, the hemolysis is going to happen. But cold antibodies are going to be active during the cold temperatures. So when the environmental temperature is becoming cold, winter season, okay, the cold temperature is going to trigger the agglutination. So hemolysis occurs at this point. Okay. And this IgG is going to, hemolysis is extravascular, predominantly in the spleen. Where the hemolysis IgG is going to happen, it is going to happen in the spleen. Intravascular hemolysis requires complement for the hemolysis. So the cold antibodies requires complement for hemolysis, and it's going to be intravascular. Okay, so IgG is extravascular, predominantly in the spleen. IgM is intravascular and it requires complement. Okay, so clinical features also differs. Since it is going to get destroyed in the spleen, you have splenomegaly, and whatever it's going to form bilirubin and jaundice. So jaundice, splenomegaly is very common in warm type of hemolytic anemias. Here, as I said, intravascular, you're going to have hemoglobinemia, haptoglobin is going to reduce, and finally you will have hemoglobin urea and hemosiderunuria. Okay, And in children, the advantage is the warm hemolytic anemia less than 12 years is very transient. It has a very good prognosis. It is very transient, often triggered by respiratory tract infections, and it settles down very fast. Like 6 months, it settled down. Okay, so the warm hemolytic anemia settles down fast. So what causes the warm hemolytic anemia? Some respiratory infections. Similarly, IgM, remember M for mycoplasma, M for mononucleosis. Okay, so mycoplasma infection is going to trigger the cold antibodies. Similarly, Epstein-Barr virus induced mononucleosis can cause the cold antibodies. And regarding the treatment, very good response with steroids for warm hemolytic anemia, very good response. Here it's going to be poor response for steroids. Okay, and if it's not going to respond to steroids, as we said, splenomegaly is going to be a problem. Splenomegaly is the main site for destruction for warm antibodies. So splenectomy is going to improve the condition. Okay, so next option for warm hemolytic anemia is splenectomy. But here in cold antibodies, splenectomy is not going to be helpful because it is going to be intravascular. So splenectomy is not helpful. And remember, you might get an MCQ where the treatment which is helpful for both warm antibody and cold hemolytic anemia is rituximab. Okay, rituximab, because rituximab targets the B lymphocytes, reduces the antibodies, be it IgG or IgM, both are reduced. It targets the B lymphocytes as a whole, and the antibody is going to reduce. So it is used in both the types. So rituximab can be used in both the types. Okay. So move on to the concept of 5. Hope you are understanding. If you have any doubts, stop ma. Okay. Understanding is important. We can go slow. Okay. So any doubts, you stop and ask me. So concept 5 is with regards to autoimmune hemolytic anemia. We said already that autoimmune hemolytic anemia is one condition where spherocytosis will be present, but differentiating feature between hereditary spherocytosis and autoimmune hemolytic anemia is Coombs test. So Coombs test is going to be positive in autoimmune hemolytic anemia. And you might get an MCQ of what is Evans syndrome. Evans syndrome is nothing but you have autoimmune hemolytic anemia of the RBCs. Similarly, an immune lysis of the platelets, which is ITP, idiopathic thrombocytopenic purpura. So it is an immune-mediated platelet destruction, ITP. Immune-mediated RBC destruction is autoimmune hemolytic anemia. So when these two are included, we call that as Evans syndrome. Something seriously big is underlying problem is there, like SLE or some connective tissue disorders will be there for Evans syndrome to happen. Okay. And one more MCQ, if they might ask you, which is the common drug, which is most common drug which causes drug-induced hemolytic anemia. So remember cephalosporins. Okay. Okay. So now comes one more confusing term. I will not say as a concept. It is a PNH and PCH. Often we get confused. Paroxysmal nocturnal hemoglobinuria, paroxysmal cold hemoglobinuria. Why it is confusing? Both are paroxysmal. Okay, both are paroxysmal, both are hemoglobinuria, but one is cold hemoglobinuria and one is nocturnal hemoglobinuria. Okay, and the moment hemoglobinuria, so remember it's intravascular. Okay, I said already no, hemoglobinuria happens intravascular, so hemoglobin, you will have hemoglobinuria. So it's intravascular hemolysis. Okay, nocturnal cold. So remember I said already cold means cold antibody, no? So it is antibody mediated, it is immune mediated. So paroxysmal cold hemoglobinuria. So remember cold antibody. So it's going to be immune mediated. But nocturnal hemoglobinuria is non-immune mediated. There is no immunological phenomenon. It is almost like a genetic phenomenon. So it's a non-immune mediated. So it is going to be a immune mediated. And what antibody we call that? We call that as Donath-Landsteiner hemolysin. So you can remember, the last are not alone. So Donath-Landsteiner hemolysin, it is a very peculiar antibody. We always say that cold antibody is IgM, no? We said it as IgM, but here alone it is IgG. So IgG cold reactive antibody. We call that as IgG cold reactive antibody. It is a biphasic antibody. It is a bit peculiar antibody. It is a biphasic antibody. because it binds to RBCs in the cold. So in the peripheries, it binds to RBCs. The antibodies are going to bind to RBCs in the cold, in the peripheries, okay, cold temperature. It's not going to lyse the RBCs. Once it reaches the center of the body where the body is warm, there the complement fixes and lyses the RBCs. So complement fixation happens in the warmth and it's going to lyse. So it's a biphasic antibody, and it is a cold reactive antibody because it binds in the cold in the peripheries. So IgG, but it is IgG. So remember, it is IgG. So it's a Donut-Landsteiner hemolysin. Previously, it used to be congenital syphilis, where we used to get this paroxysmal cold hemoglobinuria. Okay. Then, with regards to paroxysmal nocturnal hemoglobinuria, I said it is non-immune mediated. Okay. Problem is, you have two items, two proteins. One is CD55 and the other is CD59. So remember, CD55, CD59. CD55 we call it as decay accelerating factor. Okay, CD55 is called decay accelerating factor and CD59. Okay, they are going to be present on the RBC. They are going to protect the RBC from complement mediated lysis. So this CD55 and CD59 is going to protect from complement mediated lysis. So in paroxysmal nocturnal hemoglobinuria, this is not going to be there. So the CD55 and CD59 is not going to be there. So automatically the complements are going to attack the RBCs and going to cause lysis, resulting in hemoglobinemia and hemoglobinuria. So how to diagnose? You do the flow cytometry to diagnose the CD55 and CD59 and tell that it is less. So that is the diagnosis for paroxysmal nocturnal hemoglobinuria. Treatment, if I don't think they will ask you, so just remember eculizumab. Eculizumab is one drug which will work in paroxysmal nocturnal hemoglobinuria. Okay, so we will move on to the next concept, thalassemias. So thalassemias, so we need to first start with what are the hemoglobins. We should understand what are the hemoglobins. So hemoglobin A is alpha 2, beta 2. So this is the adult hemoglobin. So there will be 4 chains, of which 2 chain is alpha 2, 2 chains are beta 2. Fetal hemoglobin is alpha 2 and gamma 2. So this all, I think these three they will definitely ask sometime or the other. So fetal hemoglobin is going to be alpha 2 and gamma 2. And the other secondary hemoglobin is hemoglobin A2. Secondary adult hemoglobin is hemoglobin A2, which is alpha 2 and delta 2. So what is the normal percentage when you do in adults is in children also. Normally you have more than 95% of hemoglobin A. And less than 2.5% will be your fetal hemoglobin after birth. This I am telling about after like 3 months or 4 months. Then you have hemoglobin A2 as less than or equal to 3.5%. Okay. Also, you might ask, they might ask you some embryonic hemoglobins rarely. Okay. So you have to memorize. So Gover 1. So Gover 1 is zeta 2, epsilon 2. Gover 2 is alpha 2, epsilon 2. Portland is zeta 2 and gamma 2. Okay. So remember in thalassemia, alpha thalassemia where alpha chains is problem, beta thalassemia where beta chains will be a problem. Okay. So beta thalassemia major. So what is beta thalassemia major? So both the beta chains are absent. Okay. So both the beta chains are absent. So that is beta thalassemia major. So obviously the other two will start increasing. So you will have increased hemoglobin, fetal hemoglobin, and you will have increased HbA2. So you will not have adult hemoglobin which is HbA. HbA will be very, very less or not detectable. Okay. So what we will have in beta thalassemia major, hemoglobin F will be more and hemoglobin A2 will be more. Then you have something called thalassemia intermedia, where the beta chains will not be totally absent. They will be mutated. It could be beta plus or beta plus beta 0. So we call this beta plus as a mutated, where some amount of beta chains will be there. Okay. So therefore, hemoglobin, adult hemoglobin will not be totally absent. It will be decreased somewhere around 40-50%. It will be decreased. And hemoglobin F obviously will be increased, hemoglobin A2 will be increased, but thing is hemoglobin A will not be totally absent as in thalassemia major. And because of this, their blood transfusion requirement may be less. Sometimes they may not even require any blood transfusion at all. They will have the evidence of hemolysis, thalassemic crisis, etc. But still they manage because some hemoglobin A will be there in thalassemia intermedia. So if you are given a scenario where thalassemic features all are there, where hemoglobin A some amount is there, blood transfusion requirement is not there, then probably you are dealing with thalassemia intermedia. Then one more is beta thalassemia trait, where a single beta chain alone is a problem, the other beta chain is normal. Okay, the only way of diagnosing is they will have some amount of anemia, like iron deficiency anemia. Only way of differentiating is you do the hemoglobin A2, the other hemoglobin A2, which will be elevated than 3.5%. So hemoglobin F will not be that much elevated in thalassemia trait. So in thalassemia trait, only finding you will get in hemoglobin electrophoresis is HbA2 will be more than 3.5%. HbA2 is not so important in thalassemia major for diagnosis. The HbF only will be elevated, so remember. But in trait, HbA2 is important. HbA2 will be more than 3.5%. And for thalassemia, alpha thalassemia, you need 4 alpha chains. In beta thalassemia, it is 2 beta chains. Okay, so 1 beta chain is there, then it is trait. 2 beta chains, then it is major. If it is mutated, then it is intermedia. But in alpha thalassemia, it is 4 alpha genes. Okay, 1 alpha gene is mutated, still it is normal. They don't have any symptoms at all. 2 alpha genes are abnormal, then we have an alpha thalassemia trait. 3 alpha gene is abnormal, then the child behaves just like thalassemia intermedia, and you will have the hemoglobin H disease, which is hemoglobin H is nothing but the beta tetramers. Beta chain tetramers will be there when 3 alpha gene is abnormal. When all the 4 alpha genes are abnormal, at birth itself they present with hydrops. At birth itself they present with hydrops. They don't survive. And what you see is tetramer of gamma chains. Tetramer of gamma chains, we call that as BARTs. So you will be definitely asked some questions, maybe what is BARTs? Tetramer of gamma chains is called BARTs, 4 alpha genes, and they present as hydrops. So any child who presents with hydrops, you are dealing with alpha thalassemia. Okay. Okay. So concept 8, thalassemia is a quantity problem. Okay. And sickle cell is a quality problem. So thalassemia, everything is normal, but only the chains are less in number. Either it is absent beta chains or it is less in number as in thalassemia intermedia. Whereas in sickle cell, you will have the normal number of chains, but just the beta chains are mutated. Okay, instead of beta, we call that as hemoglobin S. It is mutated. So it is a problem of the quality in sickle cell, whereas it is a problem of the quantity in thalassemia. Okay, and what will happen in thalassemia major? I'm talking about major. So beta chains are going to be absent, the pathophysiology. So alpha chains are going to form tetramers. Since there are no beta chains, all the alpha. So for any globin chain, you need the tetramer. Either it is alpha 2, beta 2. Since beta 2 is not there, so the alpha is going to form tetramers, and these tetramers are going to lyse the RBCs. And remember, these lysis is going to happen within the bone marrow. So it is not going to happen outside as in the immune hemolytic anemia. So the tetramers are forming in the precursors of RBCs. So the lysis is going to happen within the bone marrow. And since it is going to happen before the release of reticulocytes, so reticulocytes are also not formed. So remember, thalassemia is one condition. Since it is hemolysis is happening in the precursors in the bone marrow, thalassemia is one condition, one hemolytic disease where reticulocytes are going to be low. You don't expect high reticulocytes in thalassemia. So there is a relative less reticulocytosis for the anemia. Even though it is a hemolytic anemia, you don't have reticulocytes more than 8%. And as usual, any hemolysis, you are going to get the compensatory increase in erythropoiesis. The medullary space is going to increase, and we are going to have extramedullary erythropoiesis. Okay. So concept 9, they might ask you about the mode of inheritances. So they will ask you like thalassemia is a autosomal recessive inheritance. Spherocytosis is autosomal dominant. So which means that dominant means parents may mostly will be suffering from some form of spherocytosis. So there might be a history of jaundice in the mother or the father. There might be a history of polycystectomy for the pigmentary gallstones in the family. So your case scenario will be like that. Child presenting with jaundice, splenomegaly, hemolytic features with family history of polycystectomy. So it is an autosomal dominant spherocytosis, hereditary spherocytosis. So that is the clue, autosomal dominant. So thalassemia is mostly autosomal recessive, though family history may not be there often. Okay. Then autoimmune hemolytic anemia, it is an acquired disorder. It is an acquired disorder, so there is no inheritance pattern. Okay. Sickle cell anemia is like just like thalassemia, it is autosomal recessive pattern. And G6pd deficiency is another hemolytic which is X-linked recessive. So remember X-linked recessive. So what is the significance? It's going to affect the boys alone. So in your scenario, if a boy alone is affected, so they will give 3-month-old boy. So remember, when you have a case scenario starts with 3-month-old boy, 4-month-old boy, so you are probably dealing with the X-linked recessive G6pd deficiency. With a family history, then probably you're dealing with spherocytosis. Similarly, the timing of presentation. Okay, so the beta thalassemia, so the beta chains are going to uh, be present only by 3 months of age. After 3 months of age, till then it's going to be the fetal hemoglobin. So beta thalassemia is not going to present with neonatal jaundice. So it's going to present only more than 3 months. So any child, your scenario, if it is from birth, probably it is not beta thalassemia. It could be spherocytosis. Okay. Similarly, sickle cell also same. It is a problem with the beta chain. So it's not going to present before 3 months. It's not going to present before 3 months. So before 3 months, probably you're dealing with spherocytosis or you are dealing with G6pd deficiency. But for G6pd deficiency, boys are involved, and maybe rarely they might ask about alpha thalassemia, which can present from birth. So beta chains, remember, it's going to be present from more than 3 months only. Okay. So coming to the next concept, we have only 15 minutes. Okay, so thalassemia, we said it's going to be absence of beta chains. So beta 0, beta 0. Okay. So how are you going to present? So most important presentation. So since now no chains are there, severe anemia, and they start requiring blood transfusion from 3 months of age, after 3 months, so 3 to 6 months. So the requirement is blood transfusion is more than 3 months. So I said already there will be the thalassaemic phases. So you might be given history of frontal bossing, maxillary hypoplasia, or they might give a picture of thalassaemic phases and ask you questions. Similarly, you will have hepatosplenomegaly, which is nothing but extramedullary hyperplasia. What is the major modality, major treatment modality? What is the treatment which you give Abdinaka? It's going to be transfusion therapy. So you're going to give a blood transfusion, frequent blood transfusion, 3 to 4 weeks once transfusion. The goal is going to be around somewhere around 10 grams per deciliter. So 9.5 to 10.5. So remember the goal is 10 grams per deciliter. 3 to 4 weeks you are going to give transfusion therapy. So the major treatment modality in thalassemia is transfusion therapy. But in MCQ, if they are going to ask you what is the definitive therapy, it's not blood transfusion. It's going to be stem cell therapy. Okay, hematopoietic stem cell therapy, sibling matched, HLA matched stem cell therapy is going to be the definitive therapy. Then they might ask this, my favorite, physiologically, there is no mechanism to eliminate excess iron. So there is no way to eliminate excess iron. Okay. So hemosiderosis is the complication of recurrent transfusion. So the major complication is hemosiderosis, major complication. And remember, this hemosiderosis is not just because of blood transfusion. Okay. Because even in thalassemia intermedia, who may not need any blood transfusion, still hemosiderosis is going to happen. So basic concept is whenever the bone turnover is more, RBC turnover is more, the iron absorption, naturally the body starts absorbing more iron. So hemosiderosis will be there even in thalassemia intermedia, who doesn't require blood transfusion at all. And hemosiderosis, it starts from the liver, then complication, remember any endocrine organ you tell, it's going to deposit there. So you can have hypothyroidism, hypoparathyroidism, you can have diabetes mellitus, you can have hypogonadism, hypopituitarism. You think of any endocrine, it's going to cause. Hemosiderosis is going to affect the endocrine organ. Then finally it will affect the heart. It's not final, it affects the endocrine organs and the heart. Final cause for death is due to the heart disease. The cause of death is because of heart disease and arrhythmia in hemosiderosis and iron overload. Let's talk about the concept 11 on iron overload. Okay, so serum ferritin will be increased in thalassemia, which we all know. Okay, it is so how will you know when to start iron chelation? Do the serum ferritin. Okay, serum ferritin, when it is more than 1000 nanogram per ml, it is the best screening technique. Screening technique means you take a blood test and you know, okay, iron overload is there. So serum ferritin is a very good screening technique. Ideal will be liver biopsy to know the iron content, which is a very invasive, and now slowly we are moving out of the liver biopsy. Okay, so screening technique, if they ask, it's going to be serum ferritin. Best non-invasive method, if they ask, to assess the liver and cardiac iron by MRI. So you do the MRI, liver and cardiac iron by MRI. And among this, which is the best indicator of total body iron? If they ask you an MCQ like which is the best indicator of total body iron, it's going to be the MRI of the liver iron. Okay, and they have the sequence R2 bar R2 star. I can't understand that. So remember R2 MRI. So R2 sequence of MRI for liver iron, it's not just about liver, it's about the total body iron. It's the best indicator of total body iron. Okay, and from 10 years onwards, you have to screen for cardiac iron also, 10 years of age. So what is the screening technique? Sequence is T2 MRI. T2 star MRI is going to be the sequence for cardiac iron. And iron chelation, so remember you have 3 drugs, deferoxamine, deferoxerox, deferriprone. Okay, we have only 10 minutes more, we'll go fast. Okay, so deferoxamine, deferoxerox, deferriprone. So which is safe? So deferoxamine is going to be safe and efficacious. Deferoxerox has renal toxicity. Deferriprone has agranulocytosis. So this is the side effect profile you should understand. It doesn't mean that deferoxamine is totally safe. It's better than deferoxerox and deferriprone because of the ototoxicity and retinal toxicity. But the main problem with deferoxamine is it has to be given subcutaneous, IV, very annoying. So deferoxamine has to be given subcutaneous and IV, and it's not just a single dose of subcutaneous or IV. It has to be given as an infusion for 8 hours daily. Remember, 8 hours daily, 5 to 7 days per week. How horrible the lifestyle is going to be, no? 8 hours daily, 5 to 7 days per week. So deferoxamine. But deferoxerox, even though there is a bit of renal toxicity, it is orally available once daily dose. So very easy to give. People are shifting from deferoxamine to deferoxerox because it is orally available once daily. Deferriprone is also orally. It is given as a second choice because 3 times daily we have to give orally. Okay, so we move on to deferoxerox and deferriprone. But if the iron overload is very high, we have to move with deferoxamine also, even though it is subcutaneous. Okay, and deferriprone, one good thing is it is good at reducing the cardiac iron. So if you have a scenario where cardiac iron is given, so you have to choose deferriprone because it has the ability to reduce the cardiac iron. Okay, then concept 12, small concept, hydroxyurea. So you know how hydroxyurea works. It increases the fetal hemoglobin. Okay, so it increases the fetal hemoglobin, which might be helpful in thalassemia intermedia. So in thalassemia intermedia, we are not giving any blood transfusion. So how to help out the patient? We can give hydroxyurea because it increases the fetal hemoglobin, which will be useful, no? So, and if there is a definitive cure, I said already, it's going to be the sibling matched hematopoietic stem cell transplantation. Less than 14 years will be ideal. Otherwise, the hemochromatosis and all starts. So, start your transplantation less than 14 years. Okay. Okay. So, coming to the concept 12, we move on to spherocytosis. And think we need another 15 minutes. Okay, coming to hereditary spherocytosis. So we know there are anchoring proteins. One is ankyrin and spectrin. So this is going to cause hereditary deficiency of these will cause spherocytosis. And they have asked an MCQ. We always tend to correlate S with S, but it is not so. In spherocytosis, what is the commonest anchoring protein deficiency? It is ankyrin. Spherocytosis, it is ankyrin, and for elliptocytosis, it is spectrin. So remember this. For elliptocytosis, it is spectrin. For spherocytosis, it is ankyrin. So 50 to 67% spherocytosis is because of ankyrin deficiency. Okay, and in elliptocytosis doesn't present with much of symptoms. Elliptocytosis is very asymptomatic, much of asymptomatic. It is the spherocytosis which will cause all the problem. So what will you have? Because of this anchoring protein abnormality, you will start having spherocytes, and these spherocytes will have decreased deformability. Instead of the biconcave nature, now the spherocytes have decreased deformability. They go through the spleen and they get destroyed. And since they get destroyed in the spleen, lot of destruction is happening. So automatically the factory is going to become big. So splenomegaly is going to be there. So and jaundice is going to be there. So any child with jaundice, with splenomegaly and peripheral smear, you are having spherocytes. And I said already your home stress is going to be negative. Then probably you are dealing with hereditary spherocytosis. With family history, it will support very well. Okay. And treatment, since I said spleen is the major area where the spherocytes are getting damaged because the deformability is less. So you do splenectomy, it almost becomes curative. You do splenectomy, the hereditary spherocytosis almost is curable. So if you ask any definitive treatment, it's going to be splenectomy. Okay. And for spherocytosis, and a small comparison between spherocytosis and thalassemia, maybe you might ask a question about it. One is the osmotic fragility. So osmotic fragility is increased in spherocytosis. Increased means what? They are very fragile as they are deformable. No, so you start putting in the solution osmotic. Because of the osmotic, they start lysing very fast. So osmotic fragility is increased in spherocytosis, whereas it is decreased in thalassemia. So the moment you hear osmotic fragility, don't go for spherocytosis. In MCQ, they might give you that loophole. Osmotic fragility, you don't choose spherocytosis very fast. So osmotic fragility is increased. So they are very fragile because spherocytes, they are very fragile in spherocytosis. It is decreased in thalassemia. And another few comparison is thalassemia less than 3 months, it's not going to present beta thalassemia, whereas spherocytosis is going to present from birth. And family history is going to be present because it is an autosomal dominant, but not often you see a family history in parents. Okay, although the whole family can be there. Okay, the uncles and the other, because consanguinity may be there, but the parents will not be usually suffering from thalassemia major. But spherocytosis, family history of spherocytosis, jaundice and cholecystectomy will be there. And spherocytosis is one condition where at birth maybe they have a lot of problems with jaundice, blood transfusion and phototherapy and all. Slowly they stabilize with it. They don't require the monthly blood transfusion. So if you have a history of you don't get monthly blood transfusions and spherocytes, so this is spherocytosis. But thalassemia, it's almost like every 3 to 4 weeks you are going to give the blood transfusion. Okay. And when will you suspect spherocytosis? Coombs negative, spherocytosis in the smear, and they may present with jaundice right from the birth. So neonatal jaundice. So thalassemia is not going to present jaundice right from the birth. And some features of spherocytosis, again, I'd like to say, in the indices, one indices which you should remember for spherocytosis is MCHC is going to be more than 35. MCHC is going to be more than 35. Spherocytes are going to be there. And you have increased osmotic fragility. Okay. And all the hemolysis features is going to be there. So LDH is going to be there. Increased haptoglobin is going to be reduced. Splenomegaly is going to be there. Jaundice is going to be there. All these are features of hemolysis, except the gallstones are very prominent. You have history of cholecystectomy in spherocytosis. Okay. Okay. So coming to the 14th feature, management of hereditary spherocytosis. for that sake, any hemolytic anemia, so when there is increased erythropoiesis, so remember to give folic acid supplementation. So remember to give folic acid supplementation, but do not give iron in any hemolytic anemia like thalassemia, spherocytosis, where iron overload is already a problem. So do not give iron unless there is a intravascular hemolysis. So where hemoglobin area, hemosideronuria, you are losing iron. So there iron supplementation will help. All other extravascular, all other hemolysis like thalassemia, you don't add iron, but you supplement folic acid supplementation. You have a curative treatment, which is going to be splenectomy. We don't give it more than 6 years because of you remove the spleen, they become very much susceptible. So we don't give splenectomy less than 6 years. And you might ask question about these things. After splenectomy, what are the commonest organisms they are susceptible? So remember encapsulated organisms. So what are the encapsulated organs? Pneumococcus, meningococcus, H influenza type B. So these are the encapsulated organisms which are very much prone in hereditary spherocytosis. Okay, pneumococcus, meningococcus, H influenza. Okay, and even after splenectomy, you have to keep giving, even after giving vaccination for these diseases, still you have to continue oral penicillin prophylaxis. So remember to give oral penicillin prophylaxis even after splenectomy. You might be asked question about these things. So pneumococcus, meningococcus, H influenza, and oral penicillin prophylaxis has to be given. And some few side effects of splenectomy it may be significant. So not only it improves the RBC destruction, not only it improves the hemoglobin in spherocytosis, also the platelet destruction happens in the spleen. So automatically thrombocytosis is going to happen, and sometimes this thrombocytosis can cause thrombosis. And spleen is the place where the nuclear remnants of RBCs are removed. If they're not removed, you are going to get Howell-Jolly bodies. So Howell-Jolly bodies present is a sign of good splenectomy has been done. If Howell-Jolly bodies are not there, it means that there might be some accessory spleen somewhere else. Okay. And coming to almost the last topic, I'll go a bit fast, is sickle cell anemia. Okay. So sickle cell anemia, so remember it is a mutation of the 6th codon of the beta chain, 6th codon of the beta chain, where valine is finally replaced. Glutamate is replaced into valine. So remember Valentine. So remember sickle, for violence, it is love, which is Valentine, which is coming. So glutamate is replaced by Valentine in the 6th codon. And since we call that mutated as HBS, in electrophoresis, you're not going to get any hemoglobin A. So no hemoglobin A in sickle cell anemia. You're going to get 90% HBS. And this HBS pathophysiology, whenever there is a deoxygenated state, is going to polymerize and form sickled shaped RBCs due to polymerization. And this sickle celled RBCs are going to get destroyed. Not only they are going to destroy RBCs, they are going to clog the microvasculature. So this sickled RBCs are going to clog the microvasculature, causing vaso-occlusive complications. Vaso-occlusive complications. So sickle cell anemia is characterized by this vaso-occlusive complications. It could be pain, it could be infarctions. So one important problem with this vaso-occlusive is slowly the repeated occlusion of the spleen is going to happen, so resulting in repeated infarctions, and finally asplenia in 5 years of age. Functional asplenia, although spleen is there, because of repeated infections, that spleen is going to become afunctional. So functional asplenia in 5 years. So remember one condition, even though it is a hemolytic anemia, they will give you a scenario like this. They will give exactly like a hemolytic picture, but spleen may not be there. Or they might ask you in sickle cell anemia, all are features of like, so all hemolytic features will be there except spleen. So what happens to the spleen? So because of the repeated infarctions, there will be asplenia will be there. And since the asplenia is there, they are prone for repeated infections. So they are prone for infections for which they can die also because of the splenic dysfunction. Spleen is such an important organ. So whenever there is a fever in a child with sickle cell anemia, they have asked a question like this. It is an emergency. It is an emergency because spleen is not there. They might anytime worsen. So remember to give parenteral antibiotics for that. Okay. And final 2 slides of sickle cell. So we know already that since spleen is problem, encapsulated organisms they are prone. Okay. But they are also prone for Salmonella and Staph aureus infection. So if they give you a scenario like Salmonella and Staph aureus in the blood culture for sickle cell, what will you suspect? So remember, you have to suspect osteomyelitis. It is very peculiar. Salmonella, sickle cell, osteomyelitis. And another peculiarity, this osteomyelitis usually is going to be metaphyseal, where the blood supply is very high, regular osteomyelitis. But in sickle cell alone, it is going to be the diaphysis of the long bones. It's going to be in the diaphysis of the long bones, remember. And another scenario in a sickle cell disease, a child with fever with reticulocytopenia. Usually in sickle cell and any hemolytic, you have reticulocytosis. Suppose you have reticulocytopenia, it is probably parvovirus B19 infection. So parvovirus B19 infection is notorious to suppress the cell lines, WBC, RBC. So aplastic crisis. For normal children, normal adults, this parvovirus is not going to affect much, but this conditions where hemolytic, where the bone turnover is very high, at that part, even a small shutdown is going to cause real problem, real aplastic crisis. So parvovirus is going to cause aplastic crisis and reticulocytopenia. And regarding some complications, they may not be very particular. So splenic sequestration, very much peculiar for sickle cell. So it's going to clog the vasculature, clog the spleen. So splenic sequestration, what will happen? The spleen starts enlarging very high. So splenic sequestration, spleen starts enlarging very large enlargement. Hemoglobin is going to drop and there is going to be shock. So what is the treatment? You have to give immediate blood transfusion. So we have to give immediate blood transfusion. So what this does is the blood transfusion improves the oxygenation. I said already, deoxygenated state is going to affect the sickling. So you have to improve the oxygen status. So you give blood transfusion. So if keep on it's occurring, then you have to do splenectomy. Cardinal clinical feature of sickle cell. What is the main problem with sickle cell is not just hemolysis, it is the obstruction. I said already, it is the acute vaso-occlusive pain. It is the acute vaso-occlusive pain. So for vaso-occlusive pain, you have to give liberal NSAIDs. It is a very, very painful thing. So no child should suffer from such pain. So NSAIDs you have to give, and you have to be liberal in opioids. So your MCQ might be given like, do not give opioids. Opioids are going to give drug addiction. So don't touch those things. Opioid dependency is rare in children. You have to give liberally opioids in sickle cell anemia. Then one more complication is priapism, very peculiar. Wherever stasis, it's going to affect. So splenic sequestration, priapism, okay. So by 20 years of age, 90% of boys are going to have priapism, okay. And neurological complication is also common. Acute ischemic stroke. Acute ischemic stroke is going to happen. So most important thing we should do is you have to give immediately blood transfusion. So blood transfusion is going to improve the oxygenation status and improve the stroke. But remember, whenever you give blood transfusion, there is no anemia there, no? There is no anemia. Still you are giving blood transfusion. So the problem is polycythemia and hyperviscosity. And this hyperviscosity is going to further cause stasis and going to worsen few more sickle cell crises, no? So after blood transfusion, you have to also go for exchange transfusion. So in sickle cell anemia alone, if exchange transfusion is given, you have to choose that also. So simple blood transfusion followed by exchange transfusion you have to do, because hyperviscosity is also a problem. And one MCQ, if they ask you how to reduce the incidence of stroke, any screening test is there. So remember, transcranial Doppler ultrasonography. Transcranial Doppler ultrasonography is going to find out the blood velocity. So whenever there is some obstruction, minor obstruction, no, so the blood velocity is going to increase. So whenever blood velocity is increasing, you are doing the transcranial Doppler ultrasonography, you are finding blood velocity is increased. So immediately you have to give again and again the blood transfusion. So chronic blood transfusion is going to reduce the incidence of strokes. Okay, and acute chest syndrome is a complication. And regarding the treatment, one important drug which has helped in sickle cell anemia is hydroxyurea. So remember, hydroxyurea is one drug which has helped very much in sickle cell. It has increased the hemoglobin F, it has decreased the frequency of acute pain, decreased the hospitalization, but problem is hydroxyurea is an immunosuppressant. So myelosuppression is a problem. So you have to monitor, but hydroxyurea is a wonder drug in sickle cell anemia. So all children from 9 months of age, hydroxyurea has to be given. Okay, as an add-on, we can add L-glutamine. So remember in our, we said no, glutamate is replaced by valine. So similarly, so remember this term also, L-glutamine can be used as an add-on to hydroxyurea. But definitive cure for thalassemia, just like thalassemia, sickle cell is going to be hematopoietic stem cell transplantation. So HLA matched sibling donor for hematopoietic stem cell transplantation. So the last slide, I think 10 minutes we were gone. So G6pd deficiency, most common enzyme deficiency. So remember, it is the most common enzyme deficiency. It's going to be an X-linked recessive. So boys are only mainly going to be affected. Usual history will be some drugs. So your scenario will be child having malaria. You have started anti-malarial, and after a while the jaundice has developed. So the drugs are going to cause oxidative stress, and this oxidative stress is not going to be handled because of G6pd deficiency. So the hemoglobin is going to get denatured. This denatured hemoglobin is called Heinz bodies. So it's going to go through the spleen. The macrophages are going to bite those Heinz bodies. So now the RBCs will become bite cells and they will become hemolyzed. So G6pd deficiency, intravascular hemolysis. So finally you will have hemolysis both intravascular and extravascular. You will have jaundice. Okay. And one more question they will ask you, which RBCs are more prone? It's the old RBCs which are prone for hemolysis. So it's a transient phenomenon. So old RBCs exposed to a drug, you will have a severe anemia and jaundice. Then the new RBCs, young RBCs with lot of G6pd enzyme will be there. So they are not going to get hemolyzed. So it's a transient phenomenon. So best treatment will be to avoid those drugs. What are the commonest drugs they will ask you in MCQ? Remember all the sulfonamides, all those which have this quin. Thanks for your patient listening. If you have any doubts, feel free to post in the comment section below the YouTube video. Do join our Telegram groups. It's Pete's Medusane, which is exclusively for pediatric MCQs and future video updates, and Medusane, which is for all MBBS subject videos and MCQs. I thank Medusane and organizer Raghu for giving me this opportunity. Thank you.